from intensive care. Newborn client has been assigned to you on this shift, has been admitted to the hospital for a respiratory infection. The parent states they are unable to get the client to take their medicine. After assessing the client, you ask the parent how they've been giving the medication, and they say in their bottle, but the baby never finishes the entire bottle. Then the parent asks if they can give the newborn an antibiotic left over from an older sibling's previous infection so they don't have to pay for the medication. So, first thing that I want to attack is your thoughts on the way that the parent is giving the medication.
That's not a good thing because the medication can get stuck at the bottom, and if they also never finish it, you never can guarantee that the medication's being actually given to the patient.
Beautiful. Okay, so what we would do is we are going to teach the parent how to use an oral syringe to insert the medicine in the little pouch of the baby's cheek, very slowly as they swallow it, instead of doing it in the bottle. Very good. And then what do you think about the parent's question at the end? Several factors about that.
It would be a no because they have to finish, the older siblings should finish the whole antibiotic in general, so they shouldn't give it to the infant.
So there shouldn't be any left. Okay, that's one. What's something else?
Also, aren't infants more likely to be like, their kidneys aren't developed, their liver isn't fully developed, their enzymes, so they're more at risk for the toxicity, and they're not going to metabolize the same amount as their older sibling would for that medication.
Exactly, and tied to that is going to be the fact that what do we do when we do med math for babies, for children?
Their weight.
We include their weight.
Right, so is the weight going to be the same in an older sibling and a newborn? Absolutely not. So we're going to overdose this baby if we give them something that their siblings take, right? Plus, an antibiotic pretty much expires if it's a liquid, which in the case of most children, it is in a liquid form. So several factors about this. There's one more thing I'm specifically thinking about so they don't have to pay. How would you address that as a nurse?
Could we talk to them about resources for financial assistance?
There is someone in the hospital that can help us with that. Anybody know who it is?
Would that be social services?
Yep, case management is what we call them in the hospital, which is sort of a social services, and they have a wealth of resources. They can either do a referral to an agency or hook them up with certain things, benefits, things like that. So that one sentence should be enough to request from the doctor, from the provider, a referral to case management. Okay? Several good things about that. Okay, so we educate the parent. You notice that all of a sudden the baby's not breathing. And by the way, neonate and newborn are the same thing. You listen to their lungs and they're wheezing and they're wet. That's an awful sound in a child. You check their oxygen sat and it's 46%. The baby's turning blue. You notice they're not breathing. You check for a pulse. It is absent. You press the code button. You run, the whole unit runs into the room, starts CPR. Your charge nurse calls the provider, and the provider arrives at the bedside. Okay, we give the baby epi, which is a protocol with CPR. After one round of the epi in the administration, the neonate does not have a pulse now. Respiratory therapy intubates, which means they put a breathing tube down the baby's throat. And your charge nurse calls that on the NICU, we're going to transfer the baby to another floor. You are noting that the vital signs on the monitor, you're noting the vital signs, and you reassess your patient. What are you expecting to see after giving epi?
Increased heart rate.
And you want to give me a rationale, or anybody give me a rationale? What are the side effects of epi?
Tachycardia.
Beautiful. Yes. Okay, 3 days later, you're working on the same unit, and guess what? The parents asked, since they are coming back to your floor, if you will be the nurse, because you're the most amazing nurse. So you're assessing your client, listening to the lungs, you still hear some wheezing. They have an order for albuterol, one of our medications, as needed on the medicine administration record. After calling the respiratory therapist, who they're the ones that usually give the breathing treatment, you tell the parent you're going to have the RT give albuterol. The parent asks the nurse, why albuterol? What's the best response?
Probably D.
Oh, that looked like sound effects.
Sorry, we're all sitting next to each other.
That's fine. Okay, I need a rationale.
Albuterol is a bronchodilator, so it should help opening up the lungs, restrict that, or fight off the wheezing, and help improve breathing work.
Beautiful. So catch those root words in there. You've got constriction of the airways. That's not going to improve breathing because it's tightening everything up. You've got dilation of the airways. That's opening up the airways, okay? Bonus points. What receptor are we talking about with albuterol?
B2, we say in unison.
Woo-hoo! All right, gold stars. Wonderful. It's all starting to click. All right, after administering the albuterol treatment to the client, what is the priority?
I think it's glucose levels.
Albuterol. I'm gonna go with D.
Mm-hmm.
Why?
I also think so. Because it was something I read about.
Well, I can't argue with.
There you go.
Yes, it is because beta-2 agonists do affect blood sugar. Very good. Oh, that tickled me. Okay, so congrats, your client is in great shape. You're going home, or they're going home. They're going to have several follow-up appointments. You did successfully get case management involved, getting them the resources they need. What information should be given to the client's family? And your favorite test question, select all to apply.
I think it would definitely be probably B. C, and then how to administer to for D, and then what's that for?
C and D so far.
Yeah, B, C2, because just in case of any side effects that are going to be turned into, or adverse effects.
Oh yeah, we're talking about a baby, so we got to be so careful.
Let's see if
Okay, B, C, D. I agree with that. Anybody want to add, take away?
Would A also be one?
You said A?
Yes. A.
Yes. Okay, so the only one left is E. E, yes or no?
I would say E, yes, just because some medications can have adverse, more like cause more drug interactions for over the counter drugs and supplements.
Perfect. That's exactly why that one is on there, because all of these over-the-counter supplement complementary type of things definitely interact with what they're taking, and we need to ask first. Beautiful. So the answer is all the above. And I know when you see a select all that apply, your instinct is it can't be all of them, but in this case it was. All right, let's move on to, do we have any questions on the pediatrics? All right, let's move on to geriatrics. We're going to have 2 case studies with our older clients. Okay, today you're starting to shift in the emergency room. Geriatric client arrives via ambulance. Look at those vitals: heart rate 47, BP 76 over 48, respirations 13, O2 sat 96% on 2 liters. Temperature is 95.7, and the provider's at the bedside and starts putting in orders. Okay, So what would you expect this client to look like in your mind? Okay, that's what we're thinking. So I've told you what their vitals were. So look at those vitals again. With those vitals, what would we expect them to look like, to present as? So they are going to appear probably lethargic. They're getting poor perfusion. That means they could be maybe altered mental status, or maybe just not quite clear. Maybe a little panicky. Bradycardia, 47, and it's in this particular situation, it is symptomatic. So there's some sort of impaired perfusion, circulation problem going on, okay? Might be a medicine they're taking. What else we know is that the temperature is 95.7. What does that say to you? What would you call that temperature?
Hypothermia.
Hypothermia, yes. So they're hypothermic, blood pressure's down, heart rate's down. All right, we got a respiratory rate of 13. Is that a priority or not?
No.
What's normal?
Between 12 and 20.
12 to 20. So they are on 2 liters at 96%. It's not 100%, but they are breathing okay. So our priority is going to be what? I know it's ABC, airway, breathing, circulation. The airway breathing appears to be okay at first assessment. So what is our priority?
Circulation.
Okay, beautiful. All right. So we're going to be monitoring them. What would you expect to be ordered?
Okay, so we're thinking circulation. So atenolol is the not beautiful would be with lungs. Atropine or atenolol.
Why? Atropine, possibly?
Say again, I'm sorry.
Atropine?
Atropine, okay. And what's your rationale?
Chris Pine makes my heart race, so that's how I memorized that.
Atropine has 2 uses. What are they?
Atropine, it helps your heart rate go up and to keep the fluids inside of you.
Beautiful. Okay. So atropine is going to increase the heart rate, improve that cardiac output and perfusion, improve that bradycardia, that low blood pressure a little bit. It is muscarinic, okay? It's going to block the parasympathetic vagal influence on the heart. Expected effects on this client: increase the heart rate, improve the blood pressure. Hopefully, as the perfusion improves, so should their mental status. They should start becoming themselves, more like themselves again, okay? All right, I did put a little note here on the bottom. Atropine should be used carefully in these patients because of the side effects. Okay, so what kind of side effects will be? What's that word we call them? It's right there.
Anticholinergic.
Right. And you remember when I showed that slide in the Zoom about the blind as a bat, mad as a hatter, all that kind of stuff? We are basically shutting down their secretions. They're going to hold on to urine, things like that. Our older patients hold on to these medications longer. They don't metabolize as fast sometimes, don't excrete them as quickly. So it's going to be in them longer. And if it's going to hold, be in them longer, it's going to start causing more and more of these unwanted side effects. So we have to be careful when we give them this. Okay. After we give the atropine, heart rate is now 96. We love it. Blood pressure is beautiful. Respirations are beautiful. Oxygen's at 99%. Patient spouse arrives at the bedside with a bag full of medicines from home. She states that the emergency responder told them to bring all the medicines that their spouse was on, and this is what they found. Okay, so just take a moment to look at these. You've got 1, 2, 3, 4 actually prescription medicines, but one of them, Protonix, we haven't studied yet, so don't worry too much about that one. This is what she brought in. Okay. What do you think when you see this many medications in an older client? There's a word I'm looking for.
Polypharmacy.
Polypharmacy.
Polypharmacy. Okay. And then another thing, which kind of relates to the discussion board, is non-adherence. Okay, so something's going on. Something's not a good chemical mix. Something's not quite there. So let's look into that a little bit. To help our older clients, and I am putting this out there for a reason, okay? Polypharmacy and adherence. So keep an updated medication list, maybe a family member, or they can write them down, and you want to educate them to write down the name of the medicine, how many they take, what time of day they take it. All of that pertinent information is you would educate them. Of course, we have mentioned before using the pill organizer, some sort of reminder of how many they need to take, when to take them. Understand what the medicines do. Maybe somebody's never taken the time, they've just given a prescription and not really told them what the medication's purpose is. So maybe they're not taking it because they don't think they need it. Big deal is the one pharmacy, because a pharmacist, if they see duplicates, maybe another drug in that same class, they could spot that. That's going to be a flag for them. So maybe that would help. Can we ask the provider, can something be dropped off that list? And then we need to teach them to be careful with those over-the-counter medications, combining them, monitor for side effects, any new symptoms if they start taking something new. And then this is an interesting one too that we didn't talk about, but plan those refills in advance. Don't run out, okay? And then have a medication review with the provider at least once a year. Okay. Which of the prescribed medications could lead to this client coming back to the hospital if some education is not provided? Select all that apply.
Okay.
And I will tell you, it's not all of them this time.
I think it's atenolol.
Like A is one of them.
I want to
It's
say
one of them. Mhm.
I want to say B.
Okay.
And D.
And D, okay. So we've got A, B, D. Anybody have anything different? One of these is on your list. A couple of, three of them are. All right, so atenolol, which is A, is going to be correct. Atenolol is a beta-1. Phenytoin, which is the Dilantin, anti-seizure medicine. It can make you drowsy, but it wouldn't cause these kind of symptoms that we saw, that really low blood pressure, heart rate, things like that. Bethanechol is a cholinergic agonist. So yes, it is a vasodilator. A vasodilator is definitely going to cause low blood pressure. And then Protonix is for GERD, or stomach stuff. So we're not really addressing stomach issues, and it's not going to cause a problem. All right, so atenolol, beta-1, affects the heart. Phenytoin, no. Bethanecol's cholinergic and a dilator, which is going to lower blood pressure. Okay, so I bring this up because when you are working in the hospital, most of your patients are on multiple meds, and you've got to be able to think like this. Any questions? All right, let's go through these a little bit since two of them are on our list. So if they took atenolol, it could worsen bradycardia and hypertension, decrease heart rate, worsen the blood pressure, also could cause hypothermia exacerbation, okay? It reduces the body's ability to generate heat. It also could cause them to be lethargic, maybe not mentally clear, things like that, difficulty moving. So your instinct as a nurse is going to be hold the atenolol, notify the provider. The reason why is because some combination of medicine is producing side effects that are not anticipated side effects. There's too many, the polypharmacy is causing issues. So this is a situation you do call the provider, okay? We're going to monitor the vital signs, assess for poor perfusion, which you guys will learn to do when you're in clinical. If atenolol was already taken, atropine is not going to if they'd already taken the atenolol, their vessels are going to be open. So the atropine is going to be needed. So they're going to be symptomatic. Okay, methanocol. That is one of those urinary retention medicines, okay? It can definitely cause bradycardia because it's opening up the blood vessels, and it's going to slow the heart rate. Also, one thing is it's going to cause secretions. Okay, so the last thing we need is secretions in the lungs, secretions in the gut, and start nausea and vomiting right on top of what they already have going on. That's the last thing we need. Okay, so if they were to take that, we need to educate them. This is what can happen if you do. Let's see, methanocol could increase respiratory effort and secretion buildup in the lungs. We have to think about that. So hold the medication, notify the provider, monitor those vital signs, assess for dizziness, possibly fainting from the poor perfusion, and be alert for respiratory distress. Listen to those lungs. Okay, client's doing better and will be discharged home this afternoon. What does the nurse expect to include in their education? Let's go through one at a time. What do y'all think of A?
Yes.
Okay, A, yes. Okay, B?
Yes.
Okay, C?
No,
Because?
over-the-counter medications and like complementary supplements do affect have interactions with other drugs.
That is exactly what you should pick up on. So the root of that word only should be a trigger. Okay, only. All right, D? Tricky.
I don't think so.
No,
Okay, rationale?
because what if a kid gets into their medications?
Okay, so this is the way I would answer this. We are not told, this is an elderly couple, and we're not told that they have children living in their house. So if I were to take this as a test question, I would ask for non-child-proof bottles because elderly people often have trouble opening medication bottles. Arthritis in their hands, things like that. As a nurse in practice, what I'm going to do is say, do you have any children living in the home, or do you want me to get you some non-child-proof bottles? Okay. So that's a tricky one. If they do have children in the home, then of course you wouldn't. Absolutely. All right, E?
Yes.
Okay, F?
I would say no.
Okay, one of the medications they brought from home was phenytoin. What's the side effect?
Oh, nausea?
That's
Mhm.
swelling of
It's
the gums.
Oh, okay.
Okay, and then show them how to use their blood pressure. Do we like that idea? Their blood pressure cuff? Okay, beautiful. All right, that client is done, but your shift is not. So you're back in the emergency department. Another client comes in an ambulance with a heart rate of 102. Look at that blood pressure. 198/124, respiration is 20, O2 sat 98%, temp is 97.7. What is our priority?
Get the blood pressure down.
Right, beautiful. And heart rate's high as well. 60 to 100 is normal, but the priority is going to be that perfusion, that circulation. All right. They say they don't know what's going on. Let's see if we can find out. After looking through their past medical history, their previous meds and current meds, you see this: past medical history of anxiety, OCD, panic disorder, and diabetes. Recent add of depression, currently taken in MAOI, insulin, and multivitamins. Previous medications, lorazepam, fluoxetine, and supplements. All right, talk to me. Critically think.
If the fluoxetine hadn't cleared their system yet and they just started taking an MAOI, couldn't that cause serotonin syndrome?
Perfect. Yes. Beautiful. Okay. That is excellent. And then I see a word supplements. What does supplements mean? Okay. What supplements? Because some of them are going to depress, have those sedative effects. Okay. Also, it sticks out to me that they do have diabetes. That also can affect perfusion, depending on how well they keep up with their medications. Also, what flags for me is how we are going to talk to this client. Okay, they have panic disorder, anxiety, things like that. So I'm really going to be careful in how I address them, careful not to scare them with anything. Make sure that I explain things well. I am also, what I would do in practice is actually pull the bedside chair up to the bed so that I'm at face level with them and not looking down at them, talking down to them, but actually face-to-face conversation. All these things can help. Okay. This is what we want to consider because there's multiple things here. So hypertensive crisis, the severe blood pressure and tachycardia may suggest hypertensive crisis because they are on the MAOI. Remember when I said MAOI equals tyramine and hypertensive crisis. So when you see MAOI, those two words should immediately pop up. So if this is what's going on with this client, we would need to assess their intake of foods that might have tyramine, or exactly what Rachel said. Maybe fluoxetine too soon mixing with the MAOI is causing some issues. All right. Risk of serotonin syndrome. Is it serotonin syndrome instead of the hypertensive crisis? So they started the new medication for depression, but previously took an SSRI. It has a long half-life and can stay in the body for weeks. Okay, Rachel had it right on target there. Starting an MAOI too soon can cause serotonin syndrome. That also presents with high blood pressure, confusion, tachycardia, and instability. So to rule out serotonin syndrome, we would check for muscle rigidity, sweating, tremors, agitation, confusion, and fever. Our client did not have one. All right, diabetes, medication interactions. The client is on insulin. Maybe it needs to be adjusted because of an increased stress response from a hypertensive crisis leading to hyperglycemia. Okay, MAOIs potentially alter glucose metabolism, increase the risk of low blood sugar. Okay, so that diabetes is something that we have to keep in mind. All right, MAOIs, as we learned, we don't want to be taking it with other meds. It reacts with so many things. It's so dangerous. So the SSRIs, NIs, certain over-the-counter drugs like decongestants. So are they taking anything that could interact with MAOIs? And we have to ask them when they said the word supplements, which supplements? All right, what we're going to do is monitor blood pressure. Immediate interventions may be needed if it's a hypertensive crisis that can lead to death. Okay, serotonin syndrome, if that is what it is, we would discontinue the MAOI immediately and provide supportive care. Get a full medication list. We need to know exactly every supplement, vitamin, over-the-counter, anything that has changed in the last couple of days. Tyramine intake, what did they eat? Hold any contraindicated medications, and let's think about next steps. You ask the client, why did you call 911? And they say that they were at a housewarming party, bingo, and they started feeling terrible. Which foods should the nurse ask the client if they consume that may have tyramine?
A,
And why?
because cured meats and red wine contain tyramine.
All right, I want to point out something between A and B that should stand out to you. And I did not point this out in the Zoom. When I was talking about charcuterie boards, I also brought up wine, but I did not differentiate between white and red. So I want to make sure that I show you that. Okay, so think about pickled things, preserved things, aged things, chocolate, caffeine type, some things that contain caffeine, avocados, and red wine. Okay. Patient confirms they ate cheese and smoked meats at the housewarming party, as well as a glass of red wine. So you let the provider know right away. So what do they have? Yes.
Hypertensive crisis.
Yes, yes, beautiful. Okay, so we're ruling out serotonin. We've got hypertensive crisis. Which medication does the nurse expect the provider to prescribe for the current vital signs?
So we don't
Which
wanna
our
do
priority would be that
Not
blood
this
pressure
one.
and elevated heart rate.
The beta 1 antagonist.
Beta 1, why not beta 2?
This beta 1 is related to the heart, and beta 2 is related to
Yeah.
the lungs.
Fantastic. You guys did great. What do you think? Putting those pieces together. All right. Questions, comments, concerns? See how to put it together? It's like you take it from the textbook, you start making it work, and then when you finally get to go into clinical and you see them, you actually feel their pulses and see them sweating or see them foggy or any of those kind of things. It's like, okay, this is making sense. This is making sense. The constant, can I please have some water? Can I please have some water? Now you know why they asked for water. It's like all of this starts clicking after a while. So very good. I'm excited. Y'all did great. All right, well, I don't get to talk to you again before you have your test. I will say a prayer for y'all. And I appreciate all the hard work that you're doing. And just reach out if you need me.
Thank you.
All right, you guys take care.
Thank you.
Thank you.
Thank you.
What happened?